Welcome to the Find Empathy podcast, where we discuss the interaction between health and emotions. My name is Dr. Megan Beyer, and I'm a clinical psychologist with training in health psychology, rehabilitation psychology, and neuropsychology. In this first series, we're going to focus on a population that I work with very closely, individuals and families living with multiple sclerosis. If you would like continuing education credits for listening to this episode, please head over to findempathy.com/learn. If you're a mental health provider that specializes in health populations like multiple sclerosis, please also head over to findempathy.com and click on Get Listed. We would love to list your practice in our directory, and being listed is free. We're trying to help families and people living with chronic or acute medical conditions find the providers that can help them most. In this episode, we will hear from Dr. Adam Kaplin, a neuropsychiatrist trained at Johns Hopkins who specializes in MS. He discusses the frequency of mood symptoms, interaction between mood and MS symptoms, as well as the role of the psychotherapist and when to consider referring to a psychiatrist for medication management.
My name is Adam Kaplin. I am a neuropsychiatrist trained at Johns Hopkins, where I was full-time faculty up until the end of 2020. I'm now adjunct faculty. I have worked for the past 20 years, I believe, on trying to understand better multiple sclerosis and CNS autoimmune diseases, in particular the above-the-neck effects, like depression, cognitive impairment, and other emotional related disorders. As of 2021, am the chief scientific officer at a startup pharmaceutical company called MyMD, which is geared to develop treatments for, not surprisingly, autoimmune diseases and immune-mediated depression.
We will also hear from Dr. Aviva Gaskill. Dr. Gaskill is a clinical health psychologist. She owns a private practice outside of Philadelphia and primarily works with individuals living with chronic or terminal medical conditions. She is also a partner in care for the National MS Society. She has a particular interest and specialization in suicide and risk for suicide, and she completed a qualitative research study examining the ways individuals with MS perceive and think about suicidal ideation.
My name is Aviva Gaskill. I'm a clinical psychologist. I have a PhD in psychology with health emphasis, and I graduated from the Fairclough Graduate School of Psychology at Yeshiva University. I have a small group practice just outside of Philadelphia. I work mainly with people who are chronically, sometimes people who are terminally ill. I have a strong interest and have had a strong interest since before graduate school in issues related to suicide and suicidal ideation.
Before hearing from these two experts, Dr. Kaplin and Dr. Gaskill, we are going to start by hearing from Bron Webster. You first heard from Bron in episode 2, along with Dr. Gaskill, where we discussed how MS is treated. In that episode, she discussed her own journey of advocating for MS treatment, as well as how her MS treatments changed over time. In this particular segment, she discusses going to a dark place emotionally, as well as how she worked to overcome some of these emotional symptoms. If this is your first time listening, Bron was diagnosed with multiple sclerosis and lived many years without significant symptoms. However, her symptoms progressed over time, and her story was further complicated by a diagnosis of rare cancer. We start here with her description of knowing she needed additional emotional support.
So I had a little bit of a break for recovery reasons, and I went to a very dark place. And I had to fight to get the level of support that I knew I needed. And I didn't want to just sit in a group and have a discussion around things. So I fought to get some private help through CBT, cognitive behavioural therapy. I met a practitioner who was able to help me overcome the big kind of what if it comes back question in relation to cancer, because I could not get past that particular question. Anyway, so we worked up my answer. I got my answer to that. I'd faced my mortality. And so once I sort of, I guess that's been in the depth of the deepest, darkest point. But then I was able to start moving back upwards. I've identified a gap out there in the world of MS. And I think it's because of everything that I've been through and the decisions that I've made and the situations that I faced. I identified that there are a couple of gaps in terms of having a community of people that are in a similar predicament, and then having a bit of a process of taking action for yourself and doing things and feeling that you are making a difference to your own life. So I've got a podcast that I launched that I record episodes for every week, and then I'm developing sort of standalone units that people with MS can go through. And it's really about giving a structured thinking process around certain areas and the tools and techniques to work by yourself with a group who are going through the similar things, but it's working on your own, and just asking questions such as, that thing that's made you really tired, how much value do you place on it? And it's giving the tools to be able to do that. Or when somebody has said something, that's a bit of a throwaway comment that's triggered you or that's upset you, or maybe you're in an exercise class like I was, and you're doing the exercises and you're thinking, but I could do this 3 months ago, why can't I do it now? And getting into a negative thought pattern. So I'm trying to give people the tools to be able to stop and think, actually, that's what, when they said that, when the person said the throwaway comment that's upset me, actually, they, one, haven't got a clue about MS.
Very true.
Secondly, they haven't got a clue about how that affects me. And thirdly, actually, I don't know their personality, but this is their personality, and that it probably explains an awful lot. So it's about, what I'm building is to help people to be able to build their own toolkit to be able to deal with a life with MS, because it is so difficult. And when we've got MS, we don't just go through the typical grieving process. We don't grieve once, get to acceptance, and then it continues, because every day things can be different.
Right.
So that means that every day, if something new hits us, we're going to go right back through that grieving process again. And we're going to get those feelings hitting us again and over again, whether it be a big relapse that hits us and affects us, or whether it be one little intrusive thought that's gone through our head in an exercise class that I know threw me off for a whole month because of where that one little thought took me.
Right.
So I had to go through a big process of grieving, thinking, and knowing how I was going to cope for it going forward, cope with when I get, now I know that happens, I've got a coping mechanism for it. But I think that's one of the unique challenges of living with MS, is this ongoing, it's just like a tirade of loss.
Absolutely.
And recovery.
Yeah. There's a psychologist in the US, her name's Raz Kalb. One of the things that she talks about is this repeated grieving process that people with MS have to go through. And it sounds like that's what you're describing. So being aware of those thoughts that are popping up into your mind, how they're impacting you, and then what to do about them so that they don't take you down that spiral, or they don't force you to live in that tunnel or take you on a ride for a month, but recognizing they're there, allowing yourself to grieve for a certain amount of time, but then also being able to move forward. Does that summarize it?
Yeah, I think it does. And it's one of the most unique conditions and patterns of emotions that I think actually exists. So I think for people with MS, I think it's such a unique, it's not even a cycle. It's just this ongoing happening. If you can think, one thing layers on another and on another, and just a seeming throwaway comment. So a throwaway comment might be somebody using the word disability to somebody who has not accepted that they've got a disability. That can trigger all kinds of negative, intrusive thoughts. And I think that is a valuable thing for people to think about, is the language that they're using, that might not even seem to be emotive, because MS is recognised as a disability, but I didn't recognise it for at least the first 8 years, and then it was a long time after that still before I thought, actually, yeah, I will ask for the disabled services when I go on a flight. You know, and that's a big deal.
Yeah, absolutely.
So getting over all these little hurdles, and it's wrapped up with your identity and your beliefs and your mindset and everything that goes with it.
I also think that there's many people who are managing these day-to-day thoughts and emotions who are not necessarily working with a mental health provider. This is certainly a great resource that mental health providers can direct their patients or their clients living with MS towards, to help give them some extra support in between sessions. One of the thoughts that I had as you were talking was, you worked with a provider doing cognitive behavioral therapy after or during your cancer treatments. Did that person know about MS or know about cancer? Did you feel like you had to educate them? What did you want them to know about these conditions that you were living with?
I think the question that I'd got specifically related to cancer. And so at that point in time, the MS faded into the background temporarily. I think he was one of the more top-ranked people that was more specialised to be able to deal with people that were grieving and that were dealing with something such as cancer. He knew a little bit about my cancer in terms of what I told him. But I think because I knew I needed something, and because I was already aware of what had caused me to feel stuck, he was able to come at it probably as a more general position of helping people to deal with a death or a loss. I think for anybody that is dealing with a similar kind of situation, a similar kind of client, you don't need to know everything about MS. I think what's important is to recognise that if you see 3 people with MS, they will all be experiencing totally different relapses and symptoms. They will all have totally different outlooks about their MS. And so the big message, I think, is to treat each person individually and to never second guess what they might be feeling and what they might be needing, because it is different for each person. But there are, I think what I'm identifying as I'm doing my own piece of work is that there are almost stages in each person's MS journey, irrespective of what's going on for them in their mind. I think there's sort of an overarching, when there's, if I just go through the sort of categories that I've been thinking about myself, there's when it's all brand new. I think at that point, the typical Kubler-Ross theory of loss is going to be happening. You're going to be going through your shock and denial and everything. And then you will probably reach a point where the diagnosis is sinking in. And then there will be at some point a shit's got real type of moment that is going to be the massive point of realization that, okay, I might need to start thinking about this. But before that, they might just be living in this sort of quasi denial phase. So they've got a shit just got real. And then they're going to go on and start with the struggle of what now? And start emerging out of the depths. And eventually they might go on to hit if you think of Maslow's hierarchy of needs, so they've probably covered the various different levels. And they might then get up to the very pinnacle and even go beyond and transcend and start sending out to people. So I think that you can use a lot of the tools that are already out there in existence, the different grieving models, and the different personality achievements. That's the wrong word, but I mean, with the Maslow's hierarchy of what do those people need, and those basic models I still think are still relevant for a person with a MS. I think it's helpful to just say, how does it affect you? What's going on for you at the moment?
Absolutely.
Because it could be totally, totally different. Everybody is so different.
So different. Yes.
Yeah.
One reason
and
they
also,
call it the snowflake disease, right? Because it's so different for every person.
Yeah. And there's probably going to be a lot of things that nobody's going to talk to you about as well. That everybody wants to keep secret about their bowel issues, or the fact that they're falling down and looking drunk, or the fact that they can't remember things that they might have talked to you about last week because they've had cog fog, or they're just not absorbing things, and they might not want to talk about it, or they might not remember.
I'm imagining some of what individuals can learn through the program that you're building is sort of the mindset around managing some of those symptoms as well, like cognition and fatigue and bowel and bladder issues, and what to do when those symptoms rear their ugly head. And then it makes you start thinking all of those unhelpful thoughts that pop up.
Yeah, I mean, the things that I'm building are not necessarily going to give you how to deal with the symptoms, but will help with the mindset. Yeah. And that's something that's so important. I think it is the mindset to have the self-belief that no matter what you're facing, it's important that you just keep going and you keep trying to find another way to make things work. And hard as it is, it's not in your interest to give up. It's not in your interests to stop trying to walk just because it's hard.
I am really looking forward to seeing what you build. Final question is, if people want to follow the work that you're doing and follow your podcast, go to your website, find you on social media, where can people find you?
So the podcast is on all good podcast platforms, and that one's called The MS Show. So that would be great if you can follow, subscribe, whatever you want to do on the podcast. On social media, I'm predominantly on Facebook and LinkedIn, a little bit of presence on all the other ones, and that is under Multiple Success. So based on MS, so Multiple Success is where you'll find me, and also at Bron Webster, but Multiple Success is probably the best one. So, and you'll be able to find, and there'll be some contact information on those. Just drop me a message anytime.
Wonderful. Thank you so much. Again, I really, truly appreciate all the time and energy that you put into being here today, and also all of the wonderful thoughts that you provided.
Oh, thank you so much for inviting me. It's been great.
You can hear more of Bron's story throughout this MS series. Now we will switch gears to an interview with Dr. Adam Kaplin, a neuropsychiatrist specializing in MS. We start out with a discussion about common emotional symptoms experienced by people living with this diagnosis. What do you see as some of the most common emotional symptoms or mood disorders that are experienced by people with multiple sclerosis?
Just to begin with the last one first, emotional experiences, I think there is a somewhat universal experience that certainly, if not universal, then the vast majority of patients experience, which is the why me. So when this happens, there's a lot of confusion trying to understand what is multiple sclerosis, not having heard about it, maybe not knowing anybody with it, although it's much more common than we had previously believed. It's 1 in 300 women, 1 in 500 men probably about that in that general area, and rising. But in any case, I think there's this universal, what did I do? How did this happen to me? The why me approach initially. And just to cut to the chase a little bit, I'm sure we'll discuss this more, but when they come and that's their initial question, there's kind of two levels. One is a religious kind of level, and I try to respect my boundaries and say, if it's a why did God let this happen? If that's where the person is coming from, then I refer them to their religious consultant. But I do say, but my job is to try to help you to understand, you're looking at the why me, why did this happen? What are all the negative things that happened that led to this? I try to explain that this is not anything that someone did to cause this to happen. This is, just some terrible coincidence of a number of different environmental, genetic, and emotional factors that came together that resulted in it. It's not anything someone could have anticipated or stopped, but the why me becomes, what am I going to do with this now that I have this? And in fact, although it's surprising to many people, actually the majority of patients, if you interview them down the road, will say that they, although wouldn't wish it on their worst enemy, they notice that in many ways, MS has enriched their life. They spend more time with their family, they're more empathic, more sensitive to other people's suffering. And so there are positive experiences that come from this and trying to help the person identify that. The first question you asked is, what are the most common mood related concerns? And what I have spent my time trying to do in this arena is to dispel people's mistaken understanding of what depression is. So depression with a capital D, not just when people are demoralized and their coping strategies are overwhelmed, but depression in the clinical depression sense. And this is one of the symptoms that is quite common with MS and is not like all of the other symptoms. It is due to activation of the immune system. Inflammation is what causes it. In the vast majority of cases, not surprisingly, it turns out that depression and MS have this bidirectional relationship, which is MS causes depression, but the depression worsens the MS. And now we have data that actually shows depression, believe it or not, is a risk factor for getting autoimmune diseases, including MS. And so, the way I would think about it is that this is no different than any of the mobility, bowel, bladder, pain-related symptoms that people get with MS. Depression is one of the symptoms that starts when your brain is under attack. So that is the most common. 50% lifetime prevalence after the diagnosis. Before the diagnosis, same rate as the general population. Afterwards, 50% lifetime prevalence. And at any given time in the neurologist's office, it's 1 in 4 people have a clinical depression. But in the general community, it's probably closer to 10 or 15% at any given time, which is anywhere from 2 to 5 times the rate of the general population. So it's a major aspect of MS, and much like optic neuritis and the other symptoms, people need to understand, even though there's much more stigma with this particular symptom, that this is the product of what happens when your brain is on fire from your immune system going haywire.
I think it's so important. I've heard you talk about this a couple of different times, and I think it's so important to notice that depression, anxiety, mood disorder symptoms are associated with the diagnosis itself. And because I think people, families, many physicians still consider this as like, oh, of course you would be sad if you had this difficult medical condition. But it's more than that. I mean, my understanding is mood disorders and MS is even more common than in some terminal conditions, right? So there is more to the story than it's just difficult to live with MS.
Yeah, and that's a great point. I think you put it perfectly, but just to underscore what you mentioned. So ALS, from diagnosis to death, almost guaranteed in 2 years, has a 10% rate of depression, no different than in the general, medical office, the general healthcare setting. And that's compared to up to 50% in MS. And why is that? Well, because ALS affects the nerves that go and plug into the muscles, not the central regulator of our mood. And just so people understand it a little better, not only do we now have an understanding that depression is the result of inflammation, just some of the evidence is, for example, it doesn't matter if you're in a wheelchair or upright and walking, you can be someone who gets a clinical depression. It has more to do with whether you've had an exacerbation or whether or not there are exacerbations. Many, if not most, go on without people knowing it. Inflammation going on in areas of the brain. But other pieces of evidence, we know that there are certain treatments that really shut off inflammation. Those treatments have antidepressant effects because if you shut off the inflammation causes the depression, you should have an antidepressant effect. And we see that. It's worth mentioning that now people understand that our treatments for depression, certainly half the treatment is the talk therapy and behavioral and cognitive behavioral interventions. But in terms of medications, all of the antidepressants have potent anti-inflammatory effects. And so we know that with MS, there's the highest rate of depression, but even in people without MS, turns out inflammation plays an important role in depression. So really what we're learning from MS, we're really taking back and understanding general depression. But the point is, it is the inflammation. It's not, as you put it, gee, you'd be depressed too. I think it's so easy for clinicians to be depressed themselves. Mm-hmm. So they're very sympathetic. Like, oh yes, of course you're depressed. I've been depressed, but it's not that. It's really, because by the way, if a patient gets manic, boy, they make that diagnosis in a heartbeat. If the patient says, oh, MS, I love MS, that's great, then immediately they refer that person. Yeah. But depression is accepted as a normal response, but it's really no more normal than getting manic in this context.
Well, you bring up mania, and I think that's an interesting piece. I was part of a group that wrote a review article, and we noted that bipolar and other conditions that we think of as less common in the general population are also more common in MS. So can you talk to something like bipolar? How does that show up in MS? And is inflammation the same reason why that is more common?
Absolutely. So if I can just take one step back, because half of bipolar like bicycle, you've got both highs and lows that you have. So just in terms of the lows, a clinical depression, we make that diagnosis based on having 5 of 9 symptoms, and that's decreased sleep, often waking up in the morning, not being able to go back to sleep, loss of interest where your get up and go has gotten up and gone, feelings of guilt or worthlessness, which gets in the way of people getting help or taking their medicines, low energy, low mood, concentration problems. And that can be so bad, particularly in people with MS or in the elderly, that it looks like a dementia, but this is a reversible dementia, and so you don't want to miss it. Appetite changes, people either lose a lot of weight or they don't feel satiated with a certain amount of food, so they keep eating. What's called psychomotor retardation, they just look depressed, they're not as bubbly as they normally are, and thoughts of death. So that's a clinical depression. You need to have 5 of 9 of those symptoms, at least one is decreased mood or decreased interest. But what bipolar is where your mood is capable of vibrating up and down, and particularly you can either in what's called what used to be called manic depression and now is bipolar 1, hit a full-blown mania. These are people who often think that they go through a period of time where they're incredibly sped up. So they're very distractible. They talk a mile a minute. They're kind of like the ever-ready bunny on steroids, if you will. Mm-hmm. And they do impulsive things. They're more likely to have sex, make bad decisions, spend a lot of money, this kind of impulsiveness that happens. And so this is a true bipolar 1. There is, just like a hypodermic needle is under the skin, hypomania is under mania. And that's where people get a bit sped up, and they often stay up late, and they find it a very productive time. And they don't reach that full mania, but they can get into trouble still in some of these activated states. So what turns out to be the case is that this is much like depression, much more common. And what really is the commonality that ties them together is they both are associated with elevated cortisol levels. So cortisol is the brake of the immune system. Both of these conditions are where you have elevated cortisol, and we can just speculate as to why. But the problem is it's like riding your emergency brake in your car, and then if you go to pull it and it doesn't respond, that's what depression and bipolar does, which is you're riding that emergency brake. And then when you get infected with like Epstein-Barr or something, you can't pull that brake anymore, and your immune system is off to the races. So that's why they're very common. There's another very subtle condition that in fact most clinicians don't appreciate, and you actually have to go back to Kaplin, believe it or not, and understand the original findings, but this recurrent depression where people cycle. So that's another thing. Between the first episode and the second episode of bipolar is generally 3 years, and then it's 2, and then 1, and it gets worse and worse over time. There is a condition called recurrent depression, which is really a bipolar spectrum condition and isn't well appreciated. And I will tell you, I see a majority of patients who have that kind of a depression, this recurrent depression. And it's very confusing to people because sometimes when they get put on an antidepressant, they can get more sped up, and it has different kinds of treatments, but poorly understood. But these are all on a spectrum from just clinical depression to people who have recurrent depression to people who have recurrent depression, but with these manias intervening.
Very good. And you started to talk about treatments. And before I dive into that, I know that you have done very extensive intakes with people when they come in to see you for the first time. And we don't have time, obviously, to go through that because I think they're like 3 hours long or something. Is there anything in particular that you think is most helpful for when you first meet somebody with MS and you're trying to evaluate them from a mood perspective? What are you looking for?
So that's again a great question, and there's two aspects of that jump to mind. One is what am I looking for, and the other is what does this do for the patient? The first thing is that one of the other symptoms that I didn't state and should have, because it's not part of the criteria, but boy, is it an important part of depression, is this sense of your whole world appearing to have this tunnel vision where you don't have options. And this you can imagine if you get to a place where there just doesn't look like any options and you're hopeless and you can't see a way out, that leads to suicidality. And, unfortunately, suicide is the number 2 cause of death from people from the age of, 15 to 35. And it's the 10th leading cause of death in the general population, 3rd for people with MS. So this is a lethal disease, and people should definitely not underestimate how important this is. But having said that, it is the process when you take someone through their whole life to get that kind of a history, and they understand, right, I did have this depression before, I'd forgotten, or a family member had, and they saw them come through the other side, and putting it into the context of their life broadens that perspective that they have gotten into this really narrow thing. So it's, believe it or not, taking that history is therapeutic for patients often, just to see their world in a broader context, because often, you deal with the urgency of the moment. For me, in terms of some of the things that I look for, either 2 things when I'm looking for depression. One is that it's the worst year of their life, and that's when the symptoms started of the MS. That's what we talked about with depression causing MS because of the elevated cortisol levels, riding the brake of the immune system. Or they were doing well, and they were recovering and taking medicine and everything was fine. And then they fell off their curve. Something happened and suddenly they changed. And it is important to note that people don't have sudden personality changes, late in life, suddenly for no reason. So the other thing I look for is I try to interview the caregiver, the partner of the patient, because it affects the whole family. And they often say, I want my husband back. This is not the person I married. My wife was so different from this up until X, Y, or Z time. And so that kind of dramatic transition is normally a telltale sign, of depression. Sometimes they say, oh, and when people are depressed, they're more likely to accept coming in for treatment. When people are manic, they're having a great time. They think it's everybody else's problem. So you got to talk to asking someone, have you had periods of time where you were too happy? It's kind of like, what do you mean too happy? Happy is good. So you often have to ask the caregiver and the like. Now, by the way, the other side of this is that the caregivers often have survivor's guilt. And so one of the important thing is to tend to that, because if I'm going to help my patient, they need to have somebody who's going to be able to be there for them, especially when you mix MS and depression together. It's a very hard road, very treatable, but initially very hard, and it wears the other person out. So trying to explain to them, just like oxygen mask drop down in the plane, you put it on yourself first. I try to explain that they have to go out on the weekend or spend some time with friends, because not for themselves, for their loved ones. So that's one of the other parts of taking that history that I always try to work in.
Well, and so as a psychologist, I know most of what I do is focus on cognitive behavioral therapy strategies or acceptance and commitment therapy, kind of more that talk therapy. And I know that you do some of that, but when you're thinking about treatments for people, especially with depression, bipolar, those kinds of things, what are you thinking about? What are treatments that you think are most effective?
Well, first of all, I try to send them all to you because they are going to do far better. And the other side of things is in the descriptions you have, and I'm not going to tell your story because you're the expert, but telling patients that this is a set of skills. This isn't like how long, how old were you when you stopped being breastfed? It's not like that. It's here's some skills you can develop. And we know that antidepressants kick in a bit faster, but talk therapies, like you suggest, last far longer, and people are much less likely to relapse back into a depression once they get better if they have those tools. So I try to truly, if it's something that people have a severe depression where it's wreaked havoc with their life, often it takes a while for people to get into therapy and they've gotten into difficult situations. So that's one thing. I do want to get them to you to have that very important aspect. And the other thing I will say is I think a lot that the medications, one aspect of the medications is to act as a catalyst so people can make the changes. But I tell people I could just throw Prozac at you on a couch and you'd be miserable, because you've got to go out and do the kinds of things that you develop through CBT and other kinds of talk therapies. So what I do in addition to that is, first thing I try to do is make sure if they have, I take the set of symptoms, do they have SIG-EM CAPS? And in particular, the S on that, suicidal thoughts, I will say to them, just in terms of clinicians to know this, I will say, I'll normalize it. I'll say 80, you clearly have a depression. 80% of people with a clinical depression will have thoughts of wanting to kill themselves. Have you had those thoughts? Then I will make sure that I don't normalize doing anything, because you have to tell them, even though those are thoughts, it's the wrong solution. It's the longest term solution for a short term problem. We can fix this. We can treat this. Your life is connected to so many others. Sometimes I literally had to not let patients out of my office because they were going to go kill themselves. So, that's not common. That's exceptionally unusual, but it is worth finding out how much time do you have time to work on this. And then, I look for other causes of the depression, things that will make it hard for me to treat it any other way, such as alcohol. 25% of people with alcohol trouble will get a depression, or other drugs, such as hypothyroidism. So I want to treat that. And I do then educate people about the inflammatory aspects of depression so they know it's not a personal weakness or their fault, and unburden them from those incorrect thoughts, and offer them hope, because there's great hope of the conditions that happen with MS, fatigue, pain, all sorts of other mobility problems. They're very hard to get 100% well. Mm-hmm. We can get patients 100% well from their depression with treatment. And so, of course, you're going to go for the thing that you can get someone 100% well. And I say that in the sense that sometimes when people come in with fatigue or cognitive impairment, I say, I don't know if this is 5% due to depression or 95%, but I can tell you this, it's much easier. We can treat depression. Mm-hmm. Very hard to treat cognitive impairment. So let's treat the thing we can fix. And then whatever's left, we know that's the MS. So there's that. The other thing, and I suspect this is something that you were going to get to, but I'll hop right into it, is sure. Steroids. Steroids are glucocorticoids that people get during exacerbations, are notorious for inducing either mania or inducing depression. And so it's very, very difficult sometimes. You know, I want my patients as stable as possible so that they can receive steroids if that's what the neurologist says is appropriate in that condition. But I've had some patients who will not take steroids because they don't affect the long-term outcome, but the short-term outcome is they get suicidally depressed, and that's not worth the price of admission for that. So again, here we are back to, cortisol we talked about before is elevated. It's the stress hormone, but it's also the steroid of the brain that gets, or of the body that gets released by the adrenal glands, but it is something that has a profound effect. So got to make sure you know what's going on with the steroids and the like. So then I will try to, if it's a severe depression, I will try to discuss alternatives for antidepressants. And the one thing, again, that I want them to know, as we mentioned before, antidepressants have anti-inflammatory effects. And in fact, there are double-blind studies of Prozac, for example, that show you are over 2 times less likely to have an exacerbation, even if you're not depressed, if you're put on an SSRI, in this case, fluoxetine or Prozac, in a randomized double-blind study. And there have been stroke studies. When you're hemiplegic, you have better recovery of the side that is weak if you are treated with, in that case, it was also fluoxetine, but just because that's been around so long. So I try to tell them that there are side benefits too to the antidepressants, and then tell them that all of these medicines, unfortunately, take weeks to kick in, and try to set proper expectations. They have to continue on them even after they start feeling better, because everybody says, oh, I'm great, I want to stop it. Like, oh, my headache's gone, I don't need to take Tylenol anymore. So try to set that up, but and then I will follow them and optimize the dose. I also try to choose antidepressants that are more likely to help their symptoms. So if they're not sleeping well, I'll choose a sedating antidepressant. If they're fatigued all the time, I use a stimulating antidepressant. And the only other sort of trick of the trade I will say is the response. Depression runs in families just like high cholesterol. They have the same heritability. But so does response to treatment. So I often, best response to treatment is, was that person on an antidepressant before that worked, that I know what to put them on? Or a family member, was a family member on a treatment that worked? Because that's more likely to be the one I'll choose.
Very interesting. One of the questions I had too is that, sometimes I'm working with people who've come in to see me, but they've never seen a psychiatrist, let alone a neuropsychiatrist. When do you think is a good time to make that referral? Would you refer everyone? Are there certain people that you think are best treated by psychiatry? And when would you say, yes, you really need to see a neuropsychiatrist, not just a community psychiatrist?
So those are all great questions, difficult questions, because unfortunately, there aren't a lot of neuropsychiatrists who have expertise in MS, sadly. But I will tell you, if there's anybody out there, this is one of the most rewarding jobs you could have, because these are patients who you can get dramatically better, and it's such an important aspect. You get to work as a team with, fabulous clinicians like you. There's a couple of things. One is, if the patient is actively suicidal, my advice is you want to get a psychiatrist involved, because that's just like if you have person's having angina, you want a cardiologist because they could have a heart attack, and of course you want a cardiologist on hand. Suicidality is the chest pain equivalent for psychiatrists. And you don't want to, in my opinion, just be out there alone unless you have a lot of experience managing patients who are suicidal and what's appropriate and what's not appropriate. For that reason, I would recommend if someone is actively suicidal, you want to get a psychiatrist. The other thing is I'm all for, hopefully the clinicians have, because depression's so common, it's 25% of visits in the medical clinic are due to depression, even though it's only 10% of their patients. Those are the frequent flyers. So you really need to understand depression no matter what your clinicians listening to this are doing. And hopefully they're comfortable with at least one or two different antidepressants that they can start and know how to get that done, just like they'll start some treatment for bowel or bladder dysfunction. They will have to learn how to do that. Same thing. But I would say if they don't respond, or if they seem to be getting worse, that's when I would refer them to a psychiatrist. And the other thing is, if there's a constellation of complex interwoven conditions, that's where you would want a neuropsychiatrist. That they have, heaven forbid, they have inflammatory bowel disease and MS and depression. And now, will they absorb the medicine appropriately? And there's added complexities to that. That's when I would say you want a psychiatrist, who can help with that medical complexity that you're up against.
Okay, that's great. I wanted to highlight one thing that you did while you were here at Hopkins, which is you developed a daily mood tracker that patients they got like a little prompt every single day in which they could rate their mood. And I found actually a few people who said that was incredibly helpful for them. So I was just curious about, how was that helpful to you? Because those alerts also came back to you. You got some feedback about how people were doing on a daily basis. And how do you think it was helpful to your patients?
So great question. The first thing I will say is that what prompted me to develop that was because it didn't exist at the time. Now there are many apps out there that can assist with this. So really what I would say to my patients is, let's start this medicine, go talk to Dr. Beyer, do the things that will keep you well, like make sure you eat right. Sleep is very important. Exercise, don't do the things like self-medicate with alcohol. Come back and see me in a month. And then they come back in a month and I say, okay, how's your mood now compared to how it was a month ago? That is a stupid question to ask someone because I don't remember what I had for dinner 3 days ago. Really? I'm going to ask them how their mood is now compared to a month ago? We ask that all the time, but if you think about it for 5 seconds, you realize that's an absurd question. So the beauty of texting is that you can just look back and see how their mood has been. The other thing is, making a diagnosis of bipolar disorder can be really tough, but you will actually see that mood go up and down when you use a mood tracking. The other thing is, it makes the patient just once a day say, how am I feeling? And believe it or not, that's kind of mindfulness for depression. I mean, you just are paying attention. And a lot of patients will, elaborate on this without me doing anything. And they've taught me that when the text comes in, they say, oh, I'm a 3 and I want to be a 10. So that sucks. So what am I going to do? Oh, well, I can change this in my life and I can change that in my life. One person made it so the text came in right when he got home from work because work was driving him to distraction. And when that text came in, he said, oh, right, I'm just going to leave work at home and I'm going to spend time with my family. And that texting made all the difference. So there are variations on a theme. The other thing that I will say that I was able to do, could not do without it, is get people off medicines. So sometimes people come to me and they're on a litany, a large number of different treatments, and they're afraid to get off. And I don't know if they, which one is actually helping or not. And clearing the decks can be a dangerous thing sometimes, to just say, well, let's just stop everything. That can be tough. So stopping one medicine, following what happens to their mood for a month, then saying, oh, well, that wasn't doing anything, we can get rid of that one, stopping another one, see what happens for a month. So, and then showing that data, not just to me, but to the patient, so we both have a chance to be on the same page. So, I mean, I would just say, it's the same thing as what our colleagues have found out For hypertension, if you just measure people when they come into the office, it's the terrible way of controlling hypertension. You got to measure it in between. People get white coat hypertension and it's not accurate. So same thing with checking glucose. So mood is what we're going after here, and treating patients without at least somehow monitoring their moods, I think, is a Hail Mary, and it doesn't have to be. I mean, you can get the information you need to do that.
Yeah, that's great. And I think you sort of you started to highlight this in that answer, but one of my last questions here is, you talk a lot about, and you lecture a lot about purpose in life and how that impacts people's depression and how that helps people with MS in general. And so I was hoping that you could talk a little bit about that.
Sure. So this is actually not a small thing to me. It turns out, no. But so, bringing it up, I'm just saying I don't want to monopolize your time or the people's on this, but it is important. So let me see if I can be succinct. So it turns out, this goes back to Viktor Frankl, Man's Search for Meaning. He believed that as a species, we have an inborn need to find a purpose in our life. And people said, yeah, that's great. And it correlated with better outcomes for addiction, for a number of things. And then about 15 years ago, 10 to 15 years ago, someone looked and there was a huge protective factor for people with Alzheimer's disease. So to progress to Alzheimer's disease, if you had mild cognitive impairment, which is pre-Alzheimer's, something that they saw made it you 2.5 times less likely to progress to Alzheimer's, and say, what was that? And someone figured out it was purpose in life. And subsequent to that, it turns out the number of lesions you have in your brain with Alzheimer's, they don't have as much to do with whether or not you'll be cognitively impaired than if you have those lesions and have a low purpose in life. And now, not only with Alzheimer's do we know high purpose in life correlates with being highly protective, but we know for all-cause mortality for people over the age of 50, you are up to 3-fold less likely to die from all-cause mortality. Well, how could this be? How could this happen that it has such an effect? And without, again, going into too much detail, we're back to cortisol. So I believe, and there's evidence, that people who have a high purpose in life have a lower resting cortisol. And when they have something bad happen, it goes up and it comes back down again. The reason why we have lower mortality rates is that high cortisol turns out to be bad, not just for MS, it turns out to be bad for your heart, for your blood vessels. So people die from strokes, from heart attacks. Those are the things that get people with low purpose in life. And the last thing I'll say is that Viktor Frankl turns out to be right. But the last thing I'll say is that when I try to get people to understand what they can do, I talk about having a connection, being plugged in is important. So forgiveness is how people connect to themselves. You have to forgive yourself. There's nothing you did to cause this. Gratitude, we know from positive psychology, now this is your area, you know more about this than I do, but we know that people who just think of something that they're grateful for once a day correlates with better outcomes. And that connects us to other people. And having a purpose in life where you're helping other people connects other people to us. So you have a web, and if you have those 3 things going, I think you're going to be in the best possible situation to do well over the long term.
That's wonderful. You've talked about a lot of different things here, different medications, purpose in life, and, a lot of different research. And certainly you're not going to have all of those resources on the top of your head. But is there, 1 or 2 go-to resources that if somebody wanted to follow up on some of the things that you talked about, that it would be helpful to direct them towards?
One thing that's easy is replay this, because it's too much to absorb in one sitting. That's easy. The other thing is that the MSAA, actually, I'm plugging them, I think very highly of them, but plugging them in part because they are very good about covering these things. And they just had an article that came out, I think it was last month, on purpose in life, where they interviewed me and a neuropsychologist from Cleveland Clinic. And so that's great. And I've talked about depression. If people search my name, they have to spell it Kaplin. You'll see that there's a fair amount out there of my ugly mug talking in various ways, or written up in some kind of thing. The other thing I will tell you is Nancy Davis. Every year, the Nancy Davis Foundation, she's given maybe heading towards somewhere between $50 to $100 million to support MS research. She's a phenomenal woman who herself has MS, but tirelessly works to help others. And once a year, she will post at the Nancy Davis A Race to Erase MS a chance to give back to the community. She posts online both interviews that she has, but also an interview with the heads of 7 MS centers. And then these things that doesn't exactly fit is me to deal with the mental health side of it. So that's another source.
Wonderful. Thank you so much. So I just wanted to say thank you again for your time and energy and effort for being here and sharing all of your knowledge. And I will definitely link to all the resources that you mentioned.
That's great. And the last thing I'll say is, what you're doing and what these clinicians are doing is saving lives. I mean, really, you don't know until you hear about someone dying how many people that you're saving. But, the suicide rate has gone up 30% in the past 20 years, and this is an epidemic. And so addressing this issue is a national urgency, and it's something that shouldn't happen to our patients. And so thank you for covering this topic. It's easy to let this one go, but I know that this has been something you've been front and center about covering. So thank you for the time.
In this final interview, we talked to Dr. Gaskill about suicide risk, assessing suicide, and suicide prevention in MS and other chronic illness populations. One of the reasons that we decided to talk about this together was that you had even done some research while in grad school looking at suicide in the MS population. And one reason that I thought it was really important to talk about it in regards to MS, especially for this initial program, is because we know that suicide and suicidal ideation, or thinking about suicide, is much more common in the MS population than in the general population. Hopefully, most mental health providers have experienced or talked about this topic a little bit, but to lay the groundwork, can you talk about the difference between suicide and suicidal ideation?
Yeah. And I want to be clear that a lot of providers are also averse to talking about these issues. And so it's really important for us as providers to know what makes us comfortable and uncomfortable in terms of talking about suicide and suicide risk or attempts. If someone is a patient and you're not getting your needs met and you're asking your provider, whether they're a medical or a mental health provider, for help, and they're not hearing you, you need to keep asking or ask someone else, because it can be very serious and it can lead to potentially something that increases in severity if you're not getting help and support that you need. Before we get into that, I just want to talk about some of the language. One thing that is important is we have changed the language around suicide. We don't talk about people having committed suicide. We've actually changed the language to talking about people dying by suicide. It feels a little bit more person-centered and human-centered, I think, to be able to speak about people in that way, just like we have started to talk about people who live with multiple sclerosis rather than talking about someone as an MS patient or something like that. It's important to be able to separate them from something that has happened in their life a little bit as a person. A couple of terms are suicidal ideation is one that we talk about, which is someone who thinks about suicide. And that could be something as vague as sometimes feeling like, we have to be careful. It's not quite wanting to get away, although when I hear people talk about wanting to get away, I always start to think a little bit and start asking them about, are you having thoughts about harming yourself? Suicidal ideation can be something like, I don't want to hurt myself, but if I died, I would be okay with that. The next step up from that could be someone saying, I want to die, but I'm not planning on harming myself. And then into people who are starting to consider plans or consider ways that they might hurt themselves. It's a spectrum of answers that you might get when we start to think about suicidal ideation. Suicide itself is more specifically someone who actually does something to take their own life.
Sometimes I wonder for myself when to dig into things a little bit more. And so I'd love to hear your thoughts about this. So if somebody said, I think I heard somebody recently say to me, I don't have plans to harm myself, but I I was kind of sad that I woke up this morning.
Yeah.
And so what kind of questions would you follow that up with? How would you dig into that more?
Whenever there are people that fall into certain populations, I always sort of have my ears open for any hint that there is something more going on with them. And again, that could just be someone telling me that they want to get away. That can be someone joking and laughing about dying by suicide or killing themselves. That's not an uncommon thing to do. And sometimes when you dig into that a little bit more, there is something real behind that.
Mm-hmm.
Some real thoughts there. People who are teens or people who are older adults being at higher risk, people who are in the LGBTQ world, and obviously people who live with chronic pain. And we'll talk more about this, I'm sure, but people who are chronically ill, terminally ill, people who live with chronic pain or chronic fatigue. And there are other groups as well. With that being said, we don't want to overlook anyone who falls outside of those bounds when we think about suicide. But those for me are certain moments when I kind of have my, therapist ears open to any kind of hint about it. With that being said, I think anytime anyone brings in thoughts about harming themselves, wanting to get away from it all, wanting to disappear, I would always rather ask than not ask. And the literature, and this is for everyone to know, whether you are a mental health provider or not, there's a lot of research that shows us that asking someone if they're having suicidal thoughts is never going to make someone suicidal. Mm-hmm. And so if you have a concern about anyone in your life that you care about, or even if you don't care about them really, but that, you have any sense that, this is something that they're considering at all, I would rather have you ask than not ask, because there are some really simple ways to get help, even if you yourself don't know directly how to help that person. Typically, I will ask someone, I hear that you want to get away. Can you tell me more about that feeling? I may ask them directly, have you had thoughts of harming yourself? That doesn't always correlate with someone having suicidal thoughts. Self-harming or wanting to self-harm don't always correlate with actual suicidal thoughts or attempts or plans. Mm-hmm. They often do. I will ask them, have you been thinking about killing yourself? And have you thought about how you would want to do that? While, I may have some mini alarm bells going off for myself, I help people not feel judged, because that's a big problem that happens, that people would feel judged for having suicidal thoughts. And to kind of talk from person to person, on a level of, I hear that, you're in a lot of emotional pain in your life right now, and that this feels like an option to you. So can you tell me more about that? Mm-hmm. We were talking about our grad school mentor, Fred Foley, that he said once that has always stuck with me was he said something about, when I feel really awful, sometimes I feel like I want to die or just end it, right? Whatever that means, right? To be able to contextualize suicidal thoughts in that way feels really important, that this is something that comes up for a lot of people, and that's very human. And to not make someone feel alienated or like they're wrong or bad or something like that for having these thoughts. That doesn't mean we want to allow them to go through with harming themselves, but it's important to accept that.
Right. I think really empathizing with where people are, identifying why some of these thoughts are coming up. And I think that gets to a little bit of the research that you did. And I wondered if you could speak to that a little bit more. I see in my practice that many times the individuals I work with who have MS and share thoughts of, this is just too hard, or I'm tired of living with this, or I want to get away. Sometimes those thoughts of suicide are a sense of control. If this gets worse, I have an outlet. I have a thing that I can do that puts me back in control. And you did a little bit of research around that. Can you share more?
For my master's thesis, I did a qualitative study. So I really just asked people and interviewed people about themes around their suicidal thoughts. What is the meaning of having these suicidal thoughts in your life? What do they mean for you? And I believe 16 people out of the 20 were able to say that this feeling of, and again, this was just with patients living with multiple sclerosis, this feeling of being able to have a sense of control, that my life, because of living with multiple sclerosis and maybe because of other factors in my life, feels really out of control. If things get that bad, or if I feel this terrible in XYZ period of time, there was a sense for these folks that I am a master of my own destiny. And, it's sort of a sense of regaining some control in a life that feels very out of control for a lot of folks who live with MS. And by the way, I want to be very clear. You mentioned the high rate of suicide in the MS population. The rate of suicide in people living with MS is actually calculated to be about 7.5 times the rate for the general age match population. I think it's important to really contextualize that for people living with multiple sclerosis in particular. And that's very true, or similarly true, of a lot of diseases, but it's very common in MS. The other theme that we noticed that came up a lot was, so people who live with multiple sclerosis often, and other conditions as well, often suffer from severe chronic fatigue. They are not getting the quality of sleep that people who do not live with those conditions get. Similarly, I work with folks with Ehlers-Danlos syndrome, EDS, and they get terrible quality of sleep. Their brains are not getting into REM sleep nearly as much as people who do not live with those conditions. We can all have a tendency to get tired between 2 and 4 p.m. But in this qualitative study, we found that these folks who are living with MS, I think all of them actually in the study, the 20 people who were in the study said, I feel suicidal between 2 and 4 p.m. in the afternoon, which is so interesting because that's when people feel, generally, all of us tend to feel very fatigued. And I think it's really important to recognize that fatigue in and of itself, in addition to pain, but fatigue in and of itself can really be a risk factor for suicidal thoughts. That's important because we can think about, well, what do people do when they're feeling really fatigued to try and manage those thoughts a little bit more safely or a little bit better?
That's so interesting because you always hear about chronic pain being associated with higher risk of suicide, but fatigue is not something that's talked about a lot. And it's the number one symptom in MS. It's the number one thing that people struggle with. It's the reason that people leave their jobs. And so being aware of that connection between severe fatigue and suicidal thoughts is so important. You mentioned chronic pain, you mentioned fatigue, you mentioned age ranges, but are there other risks for suicide or suicidal thoughts that you think are helpful for us to be aware of?
I think one thing that's really important to be aware of is that a lot of the risk factors for people in general to have suicidal ideation are heightened, I would say, or felt maybe more intensely in people who are living with chronic medical conditions. And so things like poverty, things like not having a strong support system or supportive network, those things in particular, amongst others, can be particular factors that get strongly heightened, both because of living with a chronic illness and then can increase the suicidal ideation for a lot of folks. Another thing that is very important is that a lot of people who live with chronic medical issues feel that they are dependent or that they're a burden on their loved ones. And I think it's really important to recognize that feeling of being a burden to someone else, and also feeling like you don't belong because you happen to live with a medical condition, are two major factors also. And so that's so important to recognize because it can also be hard when you're someone who is, especially if you're young or you live with a rare condition or something like that, it can be much harder to find people with whom you belong and people who get it. And so making sure that you're around people, whether they live with your condition or not, that just help give you a sense of belonging. I think it's interesting in thinking about MS in particular, because people who have a lower perceived supportive network, there's a lot of research showing that there's more cognitive changes in those folks. And so, again, that can go along with, these similar issues. So, again, really making sure you have a supportive network. And I know that I'm saying that like it's such an easy thing to find, but it is really important for your health, for your future, to try and find, people who understand and people who can support you.
You brought up two really important points, I think. One is finding that social network. And I talk to a lot of the people that I work with about this, and we talk about different organizations that provide the opportunity to connect with others, even if it's not a family member or a friend that you've known since childhood. But things like Can Do Multiple Sclerosis has coaching calls, which are basically big support groups twice a month. The MS Society has support groups. They also have one-on-one peer support calls that you can call and talk to somebody else who's lived with MS. There's an organization called eSupport Health that is also another place to get connected to others. So there's lots of organizations out there for people to try and get connected. I even have a few people that I've worked with who joined a swimming league for MS, and there's an MS Day program near us. So if you can look for those kinds of resources, you can start to expand your circle, and mental health providers can take the opportunity to try and find some of those resources for their patients as well. We work a condition called stiff person syndrome, which is extremely rare. And we are running a group now for people with stiff person syndrome. Actually, Dr. Abby Hughes, who's another person who was interviewed for this podcast series, is running that. So there are those resources out there, even for extremely rare conditions. The other thing that you brought up was cognitive functioning. And we know that a large percentage, 65% of people with MS experience changes in cognition. And I often see that coming out in a couple of different ways. But one is that challenges with problem solving. So when you come against something in your life that feels difficult or challenging and you're not sure how to overcome it, sometimes when your problem solving isn't as sharp as it used to be, it can be hard to see a way out of that problem. How do I manage my fatigue, or how do I manage my chronic pain or other symptoms? It can almost feel overwhelming because problem solving isn't there or isn't as sharp as it used to be. And so having those social resources, getting back to that, allows you to talk to other people who may be able to give you ideas.
Yeah. And not being scared to reach out to them and ask them, I know you don't live with what I live with, but do you have ideas for me? Do you have thoughts? And really being open to that feedback. And some of that stuff is not going to work for you, but you may find a nugget of something that can help you in there that could feel really helpful. Sometimes there's just one thing that helps people want to live and want to move forward. I do want to jump back to one thing that I forgot to mention too, in thinking about suicide in particular, is that we know that family risk, having someone who has completed a suicide in the family, is a risk factor. And I jump back to this now because there are some people who are very clear about, my so-and-so died by suicide, and I never want to do that to my family. That can be sort of that nugget of that thing that you hold on to, like no matter how bad things get. But for other people, we have to be really mindful that that can be something that can drive them towards suicide, right? My son did this, and so it feels like a way out for me too. And so we do have to be mindful of the fact that having members of the family who have died by suicide can be a risk factor for people having suicidal ideation and making suicide attempts also.
So important. A lot of times I think we associate suicide with depression, but can you talk a little bit more about maybe some of the other emotions that might be involved in a risk for suicide?
I would say things like hopelessness and helplessness, which are two different things, right? But hopelessness in and of itself is a symptom of depression, but also feeling helpless, again, feeling like you don't have the ability to maybe solve those problems is one potential example of feeling helpless. Or burdensomeness, right, is also part of that. Those are things that can be predictors of suicide risk. I think when we also talk about suicide risk, it's important to think about anxiety, being someone who's very ruminative, being someone who's a worrier. Those are basically code words for anxiety. Anxiety can be a risk factor in and of itself. People don't have to be depressed or be recognized as being depressed to be feeling suicidal. And so it's important to know that anxiety and also anger, an inability to kind of manage uncomfortable feelings, right? Sometimes people who exhibit suicidal ideation, but also suicide attempts or completion really suffer with a lot, is having challenges sitting with uncomfortable feelings. Likewise, those people tend to maybe use drugs and alcohol to excess and other kinds of risky behaviors, which, by the way, can correlate with higher suicide risk in a chronically ill population. So it's really important to, if you are drinking heavily or if you are overusing your medication or using non-prescribed medication and drugs to self-soothe, those are really important risk factors that are heightened when people are chronically ill for suicide risk.
We've talked a lot about the risk up until now, and I want to switch gears a little bit towards what do we do about it? When somebody is in front of you and they are talking about suicide, they have some sort of plan, or they are pretty clear that this is something that's been an ongoing thought for them. What are the ways that you start to address it with that person?
So I want to be mindful not to immediately jump to hospitalization. And yet always kind of, I think it's important to put that on the table sometimes when it reaches a certain level. Mm-hmm. It's not a choice that we want to make, but if you can tell me some things, some ways that you can keep yourself safe, then we can maybe work on, in spite of feeling maybe even incredibly suicidal, if you can talk about reasons for which you would not do this, for which you would not harm yourself, I can have something to work with there. I always try and think about hospitalization as a last choice. Even someone who, let's say I've been working with for a while and I feel like they need to step up their care a little bit, I'm more willing to do that if we can, again, try to avoid hospitalization. With that being said, I am not averse to hospitalizing someone if we need to, and I'm certainly not averse to sending someone to get assessed by someone who is used to very carefully determining who really warrants hospitalization and who does not. I want to hear that someone can tell me, at least, even if they're feeling this way, like a couple of the reasons why they wouldn't actually go through with it. I also will ask people, and I don't mean this as a kind of a question to throw anyone off, but I want to find out if they feel like they wouldn't be able to stop themselves from hurting themselves. If they themselves, right? Because if someone can demonstrate to me, I've had these feelings for 6 years, 7 years at the same level, and I've never followed through with them, I might talk to that person or ask them things a little bit differently, I would say, than I'm going to talk with someone who doesn't feel like they can almost stop themselves from hurting themselves. Like if the suicidal feelings almost take over and take control of them, I might work with that person differently. And that's maybe someone that I might be a little bit more open to hospitalizing.
One thing that I think about too, just to follow up on a few of your points, is if somebody does feel like they have some control, where do they have control?
Yeah.
And where do they slow themselves down if they have these kinds of impulses? Reminding people of the reasons why they want to live. If I have the conversation with somebody ahead of time of what are the reasons that you want to live, they might say something like, oh, my kids or my dog, or something like that. And so we might come up with a plan together of, if I start having these thoughts and they feel really intense or overwhelming, what are ways that you can remind yourself of these reasons for living? Yeah. I've had people say that they will keep their dog with them in bed, or they will have pictures of their kids around, or they will, whatever it is, that's going to be the reminder of why they want to change those thoughts. Yeah.
Yeah. And I think, to your point, I listened to a Hidden Brain episode a few weeks ago, and it was so great. And they were talking about a hot state, right? When we're in an emotional hot state, when I'm feeling not just sad, but incredibly deeply sad and melancholic, that feeling brain, that emotional brain is so overtaking. It's hard for that thinking brain to kind of kick in and remind us of all the reasons we want to live. And so having things like, right, lists, reminders, having a provider to sit there and remind you, don't you remember we talked about this 2 weeks ago, right? That some people are more at risk in those hot states. That could be sadness, but it could also be anger or deep anxiety or isolation and lonesomeness, right? That, being able to have that conversation when you're not in that state will allow you to, with someone who accepts you, understands you, and can help remind you of that when you're feeling in that hot state. It will help a lot so that you don't have to be the one to remind yourself of all the reasons that you want to live, because you're not going to be able to remember them when you're feeling so bad that you want to die.
And one point that I wanted to make, and hopefully you can clarify this, is that my understanding is the research shows that this idea of contracts, which used to be popular in the past, is not helpful.
Right.
Can you comment on that?
Yeah. So there people used to do something what we would call making a suicide contract with or no suicide contract, right, with your mental health provider. And they would literally sign a document where the person would talk about how they were not going to harm themselves. And unfortunately, there have been a bunch of studies that have shown that those kinds of contracts do not work. They are not things overall that really stop people. With that being said, having a good connection with a provider who really cares about you and gives something to you and that you have an important connection with, not that that's the only thing, but having people in your life who truly, truly care about you and would miss you and would feel really sad and broken if you were not there, those can be protective factors.
Mm-hmm. I wanted to, again, kind of shift the conversation a little bit to something that we were talking about before the recording started, which is, especially in chronic illness, people living with MS or people who are living with terminal conditions, there's sometimes this tenuous two-sided coin of a person's autonomy or this concept of right to die versus maybe thoughts of suicide that come up because of ableism, right? Because people perceive their life as lower or that they perceive their life as not being as important, or maybe that they don't have the same kind of quality of life that they had prior to getting their condition, their medical diagnosis. And I think it's really important that we address those kinds of concerns, right? Because a lot of them come from this idea of ableism in the world. And so I wondered if maybe you could start that conversation, because I think it is very important for mental health providers to think about these different concepts when we're talking to people who might have thoughts of suicide.
Yeah. And it actually brings me back to something that I wanted to talk about as well. So I think that it's very important for people to be able to talk to their provider about their ambivalence about suicidal thoughts, their reasons for living, right? So all of those things with openness, without judgment, with honesty, because that person can keep coming back to that provider and saying, I'm continuing to have those thoughts, or I'm feeling better, or now I'm starting to feel worse again, and things like that. And to be able to come back and have a space where you can talk about that. When people feel judged, they're more likely to run away, right? And move away from that situation. And so that could mean actually going through and harming themselves. Similarly, when we're talking about people having a right to die by assisted suicide, it's important to be able, for us as providers, to be able to have those conversations with people non-judgmentally and to be able to address what this would mean to you, right? Do you truly have an understanding of what this would mean for people around you? We were talking a little bit more about someone who is in a situation where they more passively have a right to die, being taken off of event, something like that, versus someone stopping taking their medication. Well, you're not necessarily just going to die if you stop taking your medication. It may shorten your life, or it may harm your quality of life. And really getting into all the nitty-gritty details, which vary from person to person. I always tell people I can take 100 people who are white men with Parkinson's, ages 55 to 75, and they're all going to have different symptoms, different experiences with their illness, different relationship with their condition and their symptoms. And so, it's important to really get in there and get the nitty-gritty details of all of these things. And so what I wanted to come back to actually was one technique that I use a lot as a provider is motivational interviewing. I like to really roll with people's resistance. And I think it's really important to ask permission. Can we talk about this? Is this okay for you? Getting into that sense of what's the ambivalence here? Why are all the reasons you want to do this thing? Whatever that thing is, right? That could be going on a new medication, but why are all the reasons in this case, right, that you feel like you want to die? And why are all the reasons that you feel like you're not sure that you want to die? And let's really tap into all of those particular issues without judgment. And the research really shows that when people can talk about all of the reasons that they feel the way they feel, they're often much more willing and able to move into a place of self-acceptance, to shift into a place where they make a behavioral change. Usually that's for the positive. I think talking with people about their ambivalence, about both why they want to die, but also why they don't want to die. It's very easy to talk with someone about why they don't want to die without getting them into the wanting to die space, but it's really important to talk about both. When someone in any way, shape, or form kind of pushes us into talking about one side of an argument, but not the other, we're really shoved into kind of a box, and actually we're more likely to resist that thing. So even though it can feel scary, even for us as providers, to be able to talk with someone who maybe is at very high risk for harming themselves, it's really important to be able to comfortably talk about all the reasons that person does want to die with them.
Mm-hmm. Well, it also allows them to be very open with you. I know that when I've been able to open that conversation, there's almost a sense of relief on people's faces. They don't expect you to talk about it openly without a lot of emotion. They expect you to panic and call 911.
Fortunately, a lot of providers do. Particularly in medical providers. I think mental health providers are less apt to that, but it's true. It happens a lot, unfortunately. Mm-hmm. That's important for us to really work on ourselves, work on our own feelings around suicide, and not panic and not jump the gun, so to speak.
Mm-hmm. Mm-hmm.
Issues.
Absolutely. Following up on, that last question that I posed to you, one thing that I typically do with people is that I, again, circling back around to that social support, help people to get connected with others who've lived with MS, because sometimes by seeing that somebody else has lived with this or has found workarounds or has found a way to stay engaged, gives them ideas that get them out of that mindset of, if this disease progresses, it's terrible. I can't live with this. There's a group that I was a part of through Can Do Multiple Sclerosis where one individual did not want to use an assistive device and another individual was using a motorized chair. And it was a 5-day event. In the beginning, that initial person was very resistant. And by the end of the 5-day program, just by hearing how the person who was using a motorized chair was able to do lots of things with her family and friends by using that tool, it opens that person's world up to say, oh, well, actually, maybe I can use an assistive device, and that's going to allow me to do more of the things that I want to do. And so just by exposing themselves to how other people have problem solved around some of these symptoms can help it feel less scary, get rid of some of that catastrophizing.
Yeah. And, right. The, if she can do it, I can do it too kind of thing. And I would say we sort of talked about this a little bit before you started recording, but I think this issue of if you live with a condition where people sometimes get diagnosed at younger ages, which particularly in multiple sclerosis is happening more and more, right? Unfortunately, /fortunately, like people are getting diagnosed at younger ages, which can help them get on their meds and things like that they need earlier and reduce potential complications later on. But also, I think being able to talk to someone who's lived with your condition for a really long time, if you are relatively new to this condition, whatever the medical condition is, it can help you to experience things a little differently and experience things through their eyes. There's a lot to be learned from each other there, to be able to talk with someone about how do you overcome this obstacle. On the other hand, sometimes it can be a little disappointing too, right? Because
Mm-hmm.
they haven't lived with maybe some of the abilities that you have for a very, very long time in life, and they may not even remember what it is like. But I think your point about ableism is really a really important one that you were talking about before too. That can really affect all of this stuff a lot.
Right. Well, and just to put a period on this conversation, but and maybe to give an opportunity for people to explore this topic more, there's a psychologist whose name is Dr. Erin Andrews, who does a lot of advocacy work. She lives with a disability. And one of the things that she talked about actually in a recent podcast episode that I heard her interviewed on was that many people who've been born with a disability or lived with it most of their life, if not their entire life, they tend to find a community, a disability community very early on. They realize that there are other people who are part of this community. And so they find social support earlier in life and also seek out that social support. And many times when people have a spinal cord injury or diagnosed with MS later in life, they may not even recognize that that kind of community exists or that or where to find them or what benefit that type of community can provide. And so sometimes, again, like you mentioned, being able to learn from the people who've lived with this for longer or people who have lived with a disability for a long time is a great resource for people who are new to a diagnosis or condition. So I know we've talked about a lot of different things in regards to suicide. Is there anything that you think we've left out of the conversation?
I think in terms of resources, both for patients and providers, I always want to, be mindful to encourage people if you're having suicidal thoughts, if you're thinking about harming yourself, you want to call 911 or have someone bring you to the ER immediately to your local emergency room. Another wonderful resource that is not nearly as tapped into as much as it needs to be, but is just an amazing thing in our nation is the National Suicide Hotline that anyone can use 24 hours a day, 7 days a week. It does not matter if it is midnight on New Year's, they are there to answer your phone call and to talk to you if you're having any kind of suicidal ideation or suicidal thoughts. They're wonderful. Please give them a call if you need them.
Right. And that phone number is 1-800-273-8255. Great. Well, thank you so much, Aviva, for your time and expertise on this topic. If people want to find you, your practice, or learn more about the work that you're doing, where can they find you?
So people can find me on my website, avivagaskill.com. That's AVIVA, like Viva Las Vegas with an A in front. Gaskill, GAS as in Sam, KILL, like the words gas and kill together. So it's avivagaskill.com. I'm licensed in Pennsylvania and New York, but I also am able to see people as a psychologist through PsyPact throughout the nation in about half of the US states. And so I'm always happy to talk about this stuff. And thank you so much for having me. This is great. It was really, I know suicide's not like the most fun topic, but it's really important and hits close to home for me. And so it's really wonderful to be able to speak about it with you. Thank you.
Absolutely. You're such an expert on this topic. And so it was really great to hear all your thoughts.
Thanks.
Thank you for listening to the Find Empathy podcast. If you would like continuing education credits for listening to this episode, go to findempathy.com/learn. Our goal is to help people living with challenging medical conditions find the mental health providers who understand their diagnosis. Our education, and this podcast, is focused on increasing the number of mental health providers who can help. If you are a psychologist or a mental health provider that specializes in health populations, please consider signing up on the free Find Empathy directory. Go to findempathy.com and select Get Listed. We would love to connect with you on social media. Look for us on Facebook, LinkedIn, Twitter, and Instagram. If you have suggestions for topics you would like covered by this podcast, let us know. Our email is info@findempathy.com. Finally, please know that the opinions expressed by the experts today are their own. We are not financially supported by any of the businesses or resources described in today's podcast. Also remember that the content provided today is for educational purposes only. Please seek the guidance of your doctor or mental health provider for any questions you might have regarding your own health or medical condition. Thank you so much for listening, and we look forward to you joining us in the next episode.